Hi guys, very good evening. I hope you can hear me and see me fine. I welcome you all to the Nishcha batch. How are you all doing? Well, of course, sorry for the delay. The more advanced we get in technology, the more glitches we have to face. So now I'm back and we're going to start with skin and soft tissue infections. If you've joined us, please drop a hi and hello in the chat box. I would love to meet you. Good evening, good evening, good evening. Can you hear me now, Bipresh? I hope you can hear me fine now since the mic is here. Good evening, guys. So, skin and soft tissue infections we are doing and we are going to cover in entirety. So, something that I would like to tell you that today we are going to cover certain important bacteria such as Staphylococcus, Streptococcus and Leprosy, that is Mycobacterium leprae, including the Actinomyces, which is the filamentous group. Okay? Other than that, amongst bacteria, you have anthrax, which is cutaneous anthrax, which is very important. Then you have gas gangrene by Clostridium perfringens. Both of these have been, good evening, good evening, good evening. Excellent. Right. So both of these have been covered in the 2025 FARRE lecture titled Last Minute Bonus. Okay. And the fungal infections, which is both superficial and subcutaneous mycosis, has been covered in the 2025 FARRE named, labeled mycosis. So since you guys have said that, ma'am, please cover the topics which were not covered in last FARRE, that is why I'm covering the topics which have not already been covered. So if you want to complete the unit in all respect in entirety, then please go and refer to these two lectures of last year's. And for the remaining part of skin and soft tissue, we're going to cover today. So this will finish all the bacteria. Then we will be remaining with the viral exanthems, wherein viral exanthems of childhood is what we have to cover. So in that, we'll be covering herpes parvo, that is the DNA viruses, and measles, rubella, and Coxsackie, which is the hand, foot, mouth disease, which covers the RNA viruses. Okay. So it's a jam-packed session. It's a full-on session. And then once you, after this session, please go home and, please, you are at home. Please read these, watch these lectures itself, and then you will be completely done and dusted with the entire skin and soft tissue infections. All important lines, no, of course not. See, whichever thing that you've been following forever, please follow that. Don't switch sources in the last minute, because now what you are expected to be doing is revising for your university exams. You, I know, have been a constant Nishchay batch student, so your understanding and your everything has been created on that batch with those notes, with those lectures. So stick to that is what I would say. Okay, exam is not going to be made out of any book. Like you're mentioning a particular author, exam is not going to come straight out of that book. Okay, your examiners have not just read that book. So what is important is you know the topic. Now your brain has already read it from the notes from the Nishchay batch. There is familiarity in the mind. Don't start giving the brain new information or new resources, because that will just confuse you. So you need to build up on your strength. Your strength already is that you were constant throughout the lectures. You have studied throughout the year. So now whatever you have studied itself is what you have to revise. Okay. So that is what FARRE is also meant for. Quick revision. We have been with you throughout the year. We have taught you in the batches. Now it is for the quick revision, okay, and the last minute reading that you need to do. The reason that we've brought FARRE in this handwritten format is also the same thing. That because in the lectures and in the classes, there are so many pictures and so much keeps happening that when you have finally have a blank sheet of answer sheet in front of you, are you able to recall? How are you able to adjust the answer on your sheet? Where and how you're, because at that point of time, sometimes it does not strike us that, we need to make this diagram and that diagram. So that is why in this series, that is how we're approaching. We are bringing handwritten notes to you. We're bringing the same, it's the same thing at the end of the day. What we teach in batches is what we're teaching in FARRE. FARRE is faster. It is more concise because it is only revision and it is in this format. All right. So I hope that answers your and every other student who was thinking the same thing. I hope their answers have gotten, their questions have gotten answered. Okay. So we're going to start with the bacteria. So of course, we're going to start with the OG Staphylococcus. Then we will go on to Streptococcus, then Leprosy, and then Actinomyces finally. All right. So Staphylococcus, we're going to begin. Of course, you know it, the students, they know it better than anybody else. That staphyle means bunch of grapes and coccus means round and aureus means golden. Okay, so the bacteria itself is telling you that I am a gram-positive coccus in grape-like clusters and I produce the golden pigment. So that is what you will write. It's a gram-positive coccus. It is arranged in bunch of grapes. You will tell the etymology here. Size, of course, is 1 micrometer because my students remember that the Staphylococcus is holding that golden color medal which says number 1 on it. Yes, so it is only 1 micrometer in size. It produces golden pigment colonies. So make a quick diagram. Just make a small, yellow colored agar plate, light yellow, and then put bright golden or bright yellow colonies on it, saying that this is the aureus or the golden pigment produced by Staphylococcus, which is the beta carotene pigment. Beta carotene pigment, yes. And of course, then you make a quick red colored blood agar. Simply make the white colonies with a clearing around it. Okay, so you will make these, you will make a quick blood agar, and then you will make these yeah, okay, let me draw it for you quickly. You will make a quick blood agar, then you will make these white colored colonies, and then you make a zone of clearing around these colonies, showing that this is the absolute beta hemolysis which can be seen. I've made a small diagram. So just any, these sketches which are technically correct is what is required to be made in the exam. So no hi-fi things here, no extra sketching required, nothing, just simple, scientifically correct, technically correct diagrams, right? Quickly you can make these two diagrams, so that will fetch you more marks than simply writing that it produces beta hemolysis on a blood agar and it produces golden pigment colonies on nutrient agar. So now that you've explained the bacteria, you need to definitely talk about the virulence factors. The question can come specifically as a virulence factor. Okay, so it could be a clinical case, it could be a short note. So in both the scenarios, you should first of all in brief quickly tell about the organism. How are you telling? By making the bunch of grapes, by making the golden colonies, and by making the beta hemolytic colonies. This is the basic about Staphylococcus that we know. Then of course the leading question can be about virulence factor. So of course you remember, all my students remember that always for Staphylococcus, how do we approach? We first talk about the cell wall, then we talk about the enzymes, and then we talk about the toxins, right? These are the three headings in which we tell. So, of course, there are the cell wall associated factors, the enzymes, and the toxins which are produced by the bacterium. Cell wall associated factors is the microcapsule, right? So, my students would know that we always make this cute little diagram for Staphylococcus, wherein we make this smiling coccus and then we give him a thick helmet on top, right? This thick helmet. So, this thick helmet helps me remember all the cell wall associated factors. So, what are they? First of all, this thick helmet is what? It is a thick peptidoglycan. Because no matter if we are reading Staphylococcus, at the end of the day, it is a gram-positive bacterium. And we know all gram-positive cell walls have what? All gram-positive cell walls have a thick peptidoglycan. So this guy is going to have a thick peptidoglycan. Then all gram-positive people have these lipoteichoic or teichoic acid which is coming out of them. So we make this and we say that this is the lipoteichoic acid. So all of this is common from general microbiology knowledge. This is not specific to Staph aureus. Then you know that this guy produces a microcapsule, a zwitterionic microcapsule. So we will write that also, that it has a microcapsule which is zwitterionic, right? And then it has certain attachment factors, adhesion factors on top. So this is one protein that it has on its surface, right? Then this is another protein that it has on its surface. Then there is another protein. What are these proteins? My students would remember. So how does Staph aureus progress? How does it cause the disease? It causes localized abscesses. So for that it needs to produce the coagulase. So there is one coagulase which is bound and one coagulase which is in the tube. We perform the slide coagulase and the tube coagulase for Staphylococcus. So the slide coagulase is given by the bound coagulase which is present on its surface. So here we are going to label that this is bound coagulase, right? Then of course it causes skin and soft tissue infection, so it needs to bind to collagen. So of course there is the collagen binding factor. Then there is the collagen binding factor. Collagen binding factor. All right, no problem. Then there is this one particular thing which is very important, which is called as the protein A. You all remember this. It's the first bacterium we read. So it is letter A, which is the protein A. And what does protein A do? It protects against Opsonization. So how will opsonization happen? The bacteria will be coated by these antibodies. What does protein A do? It takes an antibody and turns it around, okay, so that the FC portion is now not free. So it takes it and turns the FC portion around. So now the FC portion is not free. The NK cells cannot bind. Therefore, the opsonization cannot happen. So this is the one which helps it, protect it against opsonization. So all important, most important cell wall factors are done. Then my students know that we always draw this vomiting which it is doing. What is this vomiting? This vomiting is the enzymes that it produces. Yes, it produces certain important enzymes. So what are these enzymes? That is also very, very simple. As a rule, we say that every Staphylococcaceae family is called as Staphylococcaceae because it is a catalase producer. So of course, catalase is going to be an enzyme. We keep talking about coagulase. So of course, coagulase is going to be an enzyme. Then the bacteria has to move forward, move forward in the skin, destroying all the cells that come in its way. So what will it do to destroy the cells? To destroy the cement between the cells, hyaluronidase. To destroy the DNA of the cells, DNase. DNA's backbone is phosphate, so phosphatase. All of this it can do at high temperatures, so thermonuclease. So it's very simple. What it is going to produce? DNase, phosphatase, thermonuclease. And like I said, to break the cement of the cell so that it can cause an abscess, there is the hyaluronidase. Hyaluronidase. Simple, easy, done, all the enzymes. So many virulence factors you're writing simply by having a mind map of how one thing is leading to another, right? And then of course, you know that it releases certain arrows outside. It shoots out these arrows. What are these arrows? These are the toxins. Toxins. And we have given it this helmet, right? So this helmet will help us remember the toxins. What are the toxins? Toxins are also helmet toxins. Sabse pehle, the first thing that you drew in the answer of Staph aureus was what? You had drawn these beta hemolytic colonies. So of course it is going to release certain hemolysins, right? So what is the first toxin? Hemolysin. Hemolysin means breaking the RBC. If it is breaking the RBC, of course, it is also going to break the WBC. So breaking the WBC would be leukocidin. Then you know that it causes the short incubation period food poisoning, hai na? Within 3 hours of eating your cheese and cream and milk-based products, you start vomiting and all. What is that? That is the enterotoxin. So it is producing enterotoxin. Then it is causing the skin infections, the scalded skin syndrome, which leads to extreme exfoliation of the skin. So what is that? Epidermolytic or exfoliative toxin. And the very famous toxic shock syndrome toxin. You cannot have passed first year, second year of MBBS without knowing that it causes toxic shock syndrome, which is the tampon-related etiology. Toxic shock syndrome toxin, all virulence factors done. So this is the mind map that all of my students would have. This is the way that we have always read it. And this is the way you can write in the exam. So cell wall associated factors, microcapsule, protein A binds the FC portion, leads to co-agglutination and immune evasion. What does it do? Twists and binds the FC portion. Now the FC portion is not free. Okay? To bind to the NK cells. Clumping factor, collagen binding proteins, सारा कुछ हमने लिख दिया. Clumping factor क्या है? It is the same as bound coagulase. Same thing as bound coagulase. Enzymes, coagulase, hyaluronidase, DNase, thermonuclease phosphatase, and of course the catalase also. Then toxins, hemolysins, leukocidins, exfoliative toxin, enterotoxin, and toxic shock syndrome toxin, right? Other things, it can also help in biofilm production. Then if you have the time and the question is primarily focused on the virulence factors of Staph aureus, then you can write a little bit about these hemolysins. What are the hemolysins? Alpha, beta, delta, and gamma. All three are produced by it. Okay, it lyses the RBCs and it shows the narrow zone of beta hemolysis around the colonies on blood agar. So you can write 3 points about it very easily, and you know them already. You know it already. Nothing new I'm telling you, right? Then leukocidins, you have the Panton valentin factor, which is a synergohymenotropic toxin. What does it do? Leukocidin combines with the Panton valentin factor, leading to synergy or enhancement, right? So you can write a little bit about that, and you know that this synergic is seen in the community-acquired MRSA strains or the CA-MRSA strains. Then, of course, the epidermolytic toxin leads to scalded skin syndrome, and enterotoxin, which gives the 1 to 6 hours food poisoning. Toxic shock syndrome, which is a super antigen, and it leads to the toxic shock syndrome. All right, just one line you can write if the question is primarily focused on the virulence factors. If the question is not primarily focused on it, this is just something that you're writing extra, then it is better to just make the list or to draw this diagram also, that's fine. Because if this diagram is going to help you remember, then you can draw it. Whatever your mind has practiced, just do that. There are no rules really. Okay, you should have just written the right thing in the answer sheet. That is what is important. Then we talk about the pathogenesis and the clinical manifestations, right? So of course, first of all, it has to adhere to any place. So what all was it using for adhesion? It was using the lipotecoic acid, it was using the microcapsule, it was using the clumping factors, it was using the protein A. All of these things it was using to first attach to the host surface. Then invasion, it is releasing these enzymes for invasion, the DNase, thermonuclease, hyaluronidase, catalase, all of this, why is it releasing? So as to invade deeper and deeper into the tissues. Immune invasion, of course, the microcapsule is helping it to evade immune system. The protein A is helping it evade immune system. Why? By binding to the Fc portion of antibody. Now antibody is not free to bind to NK cell. So what does not happen? Opsonization cannot happen. Metastatic spread, then of course, if it has invaded deep enough, it can ride onto your bloodstream and go and affect any organ of the body. So what is this telling me? That the clinical features of Staph aureus is not limited to skin and soft tissue. Yes, it is in fact the most important cause of osteomyelitis. It is the most important cause of bacterial, native valve bacterial or acute bacterial endocarditis, which we remember as ABE, right? Most important cause of ABE. It is most important cause of septic arthritis. So it is very, very important as in terms of systemic infections. So what are the clinical features? Of course, there are the skin and soft tissue infections. So of course, it is known for causing abscess. So breast abscess, skin abscess, any abscess, then the boils, folliculitis, which we all get on the hair follicle, impetigo, cellulitis. Cellulitis is what? Now it has reached the subcutaneous plane. That is the skin manifestations. Then invasive systemic infections. Like I said, endocarditis, especially acute bacterial endocarditis. It is overall the most common cause of bacterial endocarditis. Osteomyelitis, it is the most common cause of osteomyelitis. Septic arthritis, then it can go to the lungs, leading to pus formation there, leading to empyema and pneumonia. So what is the most important thing about Staph aureus? That it is also a pyogenic bacterium. It leads to pus production. Okay? So pus production can happen on the skin and soft tissue. It can happen inside the lungs. It can happen inside any organ for that matter, leading to empyema, pneumonia, endocarditis, osteomyelitis, septic arthritis. Most common cause of it. Most common, most important cause. Okay? So the students, they tend to remember the boils and impetigo and everything because we read it under skin and soft tissue unit, but they forget about acute bacterial endocarditis and osteomyelitis. So don't make that mistake. Remember it, because in your life you're going to come across patients who most commonly associated with staph in these diseases. Okay. Then toxin mediated diseases. Of course, the scalded skin syndrome is because of the exfoliative toxin. The food poisoning is because of the enterotoxin, and the toxic shock syndrome is because of the toxic shock syndrome toxin 1, right? Then it can lead to healthcare associated infections. So any catheter associated, right? So because it can be found on the skin or in the hospital environment, you're putting a catheter in a patient, it goes inside. It can also lead to QARTI. Absolutely any hospital acquired infection it can cause, it can cause QARTI. It can cause CLABSI or CRBSI. It can also cause ventilator-associated pneumonia. It can also cause surgical site infections. So absolutely any HAI, hospital-acquired infection, can be caused by the Staphylococcus. Okay? Done. Then you will talk about lab diagnosis, which is the most important thing. Of course, you're doing microscopy. So what is the dictum of lab diagnosis for all bacteriology? Number 1 is gram stain microscopy. Number 2 is culture. Then there is gram stain microscopy from that culture. Then there is the biochemical tests, special tests, and automated. These are the 6 headings in your right. Always write lab diagnosis. So you are going to, and I always tell you that how to end and begin an answer on pathogenesis and lab diagnosis. You know it, that always pathogenesis starts with mode of infection, ends with clinical features. And lab diagnosis starts with clinical features and ends with the treatment or antibiotic susceptibility. This is the dictum, this is the rule. So always your See, it is not spread majorly by respiratory route. It inhabits the anterior nares, but respiratory droplet transmission is not the mainstay. It is mostly contact spread. Okay. All right. So, yeah. So, mode of transmission is contact. Then you will write all the pathogenesis. You will end with the clinical features, which we have all just discussed. Then you will write about lab diagnosis. So, first of all, lab diagnosis is always gram stain. So, it is gram positive cocaine clusters. You can also make that little diagram again over here. Culture can be done. Again, nutrient agar, the golden pigment colonies, blood agar, the beta hemolytic colonies. Diagrams of that have already been made. Now, you have talked about a basal media, which is nutrient agar. You have talked about a enriched media, which is blood agar. Now, you talk about a selective media. For any bacterium that you're reading, for any bacterium that you're writing the answer of, always think in these three headings. Number one is the basal media. So, if it is a fastidious organism, there will not be any basal media. Then is enriched media. So, all will have their own separate enriched media, and then finally all will have their own separate specific selective media. Okay? So, same but Staph aureus is a non-fastidious guy. So, it will grow on nutrient agar giving me the golden pigment. It will grow on blood agar giving me the hemolytic colonies. Then the selective media for it is the mannitol salt agar, which is MSA, which is selective and differential. So, what does Staph aureus do? It ferments mannitol. Therefore, it gives me these yellow colonies on this pink agar. Okay. Absolutely correct. Non-diffusible pigment, because diffusible pigment is of Pseudomonas. So, Staph aureus has a non-diffusible pigment. It does not color the agar golden. The only colony is golden. All right. Correct. Non-diffusible pigment. Then, yeah. So, that is how you differentiate based on mannitol salt agar. Selectively allow Staph aureus to grow because of the salts, and selectively Staph aureus gives the yellow colonies because of sucrose fermentation. ठीक है? फिर biochemical test में it is Staphylococcus because it is catalase positive. So that is the first thing you will write, catalase positive. Then every time you have a catalase positive, gram positive cocci, the next step you do is coagulase to differentiate between Staphylococcus aureus and the other staphylococcal species or the cons. Right? So, what is the difference? Staph aureus is both slide and tube positive. Both slide and tube positive. Just to flaunt extra knowledge to the examiner, and if you have the time, and only if you have the time, you can draw this table. You can write that I am talking about the coagulase enzyme, and I am telling the examiner that slide and tube. Okay, and slide and tube. So, if both slide and my bad. Here I am writing slide, here I am writing tube. If both slide and tube are positive, okay, both slide and tube are positive, then this becomes your Staph aureus. Staph aureus, right? If slide is positive but tube is negative, then this is Staphylococcus lugdunensis. Lugdunensis, right? This, the Staph lugdunensis is the reason that we started doing tube coagulase test. This is a very important Viva question which examiners ask. Why did we start doing tube coagulase when slide was coming positive? Because of Staph lugdunensis. It used to give slide positive, but tube used to be negative. So, a lot many non-pathogenic species used to get reported as Staph aureus wrongly. Okay, that is why we do this. Then you have the other guy who's slide negative but tube positive, and that is Staphylococcus schliefferi. And then finally, you have both slide and tube negative, which are the true cons, which are your Staph epidermidis and your Staph saprophyticus, both of which we are going to discuss after 1 or 2 slides, right? So, after 1 or 2 slides, we are discussing both of them as well. So, this is extra knowledge which all my students have. This is the correct time and place to write this knowledge also in the answer sheet, because you're already talking about the coagulase test. So, instead of simply writing coagulase test in a line, you can give that the heading and make this table, and then move to the next biochemical, which is your DNase thermonuclease phosphatase. So, what do I always tell my students, never get confused in lab diagnosis, because the only thing we detect in lab diagnosis is the virulence factors. You will see that I have not detected anything other than the virulence factors. Up tak maine, what all have I said for the lab diagnosis of Staph aureus? I have taken the name of catalase, we have talked about it. I've taken the name of coagulase, we have talked about it. I've taken the name of your beta hemolytic colonies, hemolysin, I've talked about it, right? I've taken the name of all the enzymes, DNase, phosphatase, thermonuclease. All the virulence factors itself I am checking in the lab diagnosis. So whenever you get confused or whenever you feel like you're going blank in the exam, just remind yourself of the virulence factors. Or if you have written the virulence factors right on the back page, just turn and see and then simply write the same thing in the lab diagnosis, that this is what I will detect. It's the same things we detect in the lab, nothing else, okay? Right. So coagulase test, clumping positive, and tube means that there is clot formation in the tube. So you can make these simple line diagrams, simply draw a slide, make some clumps and say that this is slide positive. Make a tube, make a solid clot in it and say that this is tube positive, right? These simple diagrams can definitely be made, all right? Then you talk about the treatment, है ना? You end lab diagnosis with treatment. So treatment, of course, for all the gram positives, the penicillin groups is very important, but there is very important resistance, which is the MRSA, methicillin resistant Staph aureus. क्या है? MECA gene mediated. Please write the letter MECA gene. What does the presence of MECA gene do? The bacterium changes its penicillin binding site into penicillin binding protein 2A. Now your methicillins or your penicillins cannot identify this binding sites, so they cannot bind to the bacterium, so they cannot kill the bacterium. Okay, that is MRSA, resistance mediated by MECA gene. It alters the penicillin binding protein. Now, this bacterium has become resistant to all beta-lactam antibiotics. So, it is going to be resistant to monobactams, penicillins, first, second generation cephalosporins, every beta-lactam drug, it is going to be resistant, right? Then it also produces VRSA, which is vancomycin-resistant Staph aureus. There it is rendering resistance to vancomycin, and that happens by the VAN-A gene. And what does VAN-A gene do? It replaces the D-ala side chain into D-ala D-lactate or D-ala D-serine, right? So that is what it has changed. So vancomycin was supposed to go and attack this D-ala side. So if you remember the peptidoglycan diagram of the gram-positive bacteria, in the tetrapeptide side chain at the bottom there was D-alanine, okay? So that D-alanine, it attacks vancomycin. What will the bacteria do? It will change it from D-alanine to D-alanine D-serine or D-alanine D-lactate. So the vancomycin will not be able to identify it and it will not be able to stop the bacterium from producing the cell wall. The bacteria will successfully produce the cell wall and be very, very resistant to the vancomycin. ठीक है? Must write. It is a must write. Even if the question simply says treatment, just try to somehow include the points of MRSA and vancomycin resistance in the answer sheet. Okay, very, very important to know. So of course, how will you treat? There is, if it is a if it is some gangrenous site or toxic shock syndrome, then debridement and removal of colonizing substances is very, very important. So this is the treatment for your toxic shock syndrome. For toxic shock syndrome, you will do fluid replacement, you will do debridement of that area, you will remove the contaminating substance. So if it's some clothes, you will remove that. If it's a tampon, you will remove that. Whatever is the source of infection, that has to be removed. The drug of choice is clindamycin and linezolid for the MRSAs, okay? And if it is also linezolid resistant, then finally you have vancomycin, okay? And if it is vancomycin resistant, then God help you. We don't know what else to do, right? Control MRSA in the hospitals. How? We do contact precautions and decolonization of carriers. This is an important point that if you write, you will fetch very good marks, okay? Because this is something which is very advanced knowledge and this is something which will tell the examiner that you have really actually understood the importance of Staph aureus in your life. ठीक है? Decolonization of carriers with mupirocin ointment is a prevention strategy. It is a control and prevention strategy. How do I make sure that the patients admitted in my hospital don't get these hospital-acquired infections with Staph aureus? I screen them. I screen the patients. I screen the staff for colonization with Staph aureus. Because like I said, where do we colonize it? In the anterior nares and in the hands. So anybody who's colonized with MRSA MRSA will spread it to the patients in the hospital. So it is good to screen them, whoever comes positive, give them 7 days of mupirocin ointment treatment, and once they have been decolonized, you let them into the hospital again. This is the most important prevention strategy, especially for surgical patients and especially for patients who are going to get the central line catheters inserted in them. ठीक है? तो Kirby-Bohr disc diffusion is the method of antibiotic susceptibility testing. तो आपने treatment की बात कर ली, आपने antibiotic resistance की बात कर ली. Of course, no microbiology answer is complete without writing about AST, antibiotic susceptibility testing. How do you do it? You can do it by disc diffusion or broth dilution. For every answer, for every bacteria, first you make these two headings. That is disc diffusion and broth dilution. Disc diffusion, which is the most common method, Kirby-Bohr's disc diffusion. And what are we doing? We are putting a single disc of cefoxitin. We are putting a single disc of cefoxitin, and then we are looking at the zone of inhibition. If the zone of inhibition is present, then this guy is methicillin sensitive Staph aureus. Okay. And if the zone of inhibition is absent, okay, if the zone of inhibition is absent, meaning this guy is resistant to cefoxitin. So resistance to cefoxitin is telling me that this guy is MRSA, because this is a surrogate marker. Okay? So this guy is MRSA. If you write this point, you're getting distinction. Trust me. This is something that students tend to forget towards the end. But please remember that since you are talking so much about MRSA, then you should also know how to detect MRSA in the lab. So how will you detect MRSA? By detecting resistance to cefoxitin. If cefoxitin is sensitive, the bacterium is also sensitive. If cefoxitin is resistant, meaning bacterium is MRSA. So what is that one marker of MRSA? Cefoxitin resistance on the Kirby-Bohr disc diffusion test. I hope it has grilled into your brains. Next is cons. I told you we'll talk about two important cons, which is Staph epidermidis and Staph saprophyticus. Now the name itself is telling you epidermidis. It is present on the epidermis. So it's a part of the normal flora of our skin. So what will happen? The surgeon is doing something. The surgeon is putting a pacemaker in your heart, and he is supposed to reach the heart by cutting open the skin. If the surgeon fails to properly and nicely disinfect or do asepsis of the skin, he is going to introduce all the skin flora into the new pacemaker or into the new prosthetic valve. So which is the most important cause of prosthetic valve bacterial endocarditis? It has to be Staphylococcus epidermidis. Okay, it is a part of the normal skin flora. It frequently causes prosthesis or implant infections. So infective bacterial endocarditis on prosthetic valves is your Staphylococcus epidermidis. So bacterial endocarditis, acute bacterial endocarditis of native valve is Staph aureus. Acute bacterial endocarditis of prosthetic valve, implants, pacemakers, catheters, your bone implants, any kind of implant is Staph epidermidis. Okay, because it also makes something which is called as biofilm. Biofilm. So it will make these biofilms on the catheters, inside the catheters. It will make this biofilm on the implant surfaces. So that is why it is the most important cause of, like correctly said, iatrogenic and hospital associated infections in the implants and in the catheters. Okay? Then Staph saprophyticus is found in the perianal region or found in the vaginal flora. So it causes what? It causes honeymoon cystitis. Honeymoon cystitis. So you will have a young reproductive age female having UTI because of Staph saprophyticus. Now how do we differentiate between Staph saprophyticus and epidermis on a culture plate? By looking at novobiocin resistance. So I will put a novobiocin disc and I will show this novobiocin disc to both the bacterium. The bacterium which is resistant, so you know S is not S. If it is resistant, then it becomes your saprophyticus. Okay? Saprophyticus is resistant to novobiocin, whereas epidermis disc is sensitive to novobiocin. That is how you differentiate between the two. So if the question says cons, if the question says OSS, if the question says honeymoon cystitis, if the question says See, epidemiology actually needs to be only added to the questions where it is relevant, such as like you said in Vibrio cholerae. In Vibrio cholerae, epidemiology is relevant. But epidemiology is not relevant in Staphylococcus. It happens in the developed countries, it happens in the developing countries, it happens everywhere. Okay, so epidemiology is only important where it has been mentioned. The good thing with you is you really need not learn the questions in an essay format because you're going to have leading questions. And if it's a short note, then I don't think you will have enough time to write about epidemiology. Unless questions specifically asks about epidemiology. What will they, in whom will they ask epidemiology? They will ask in Vibrio, they will ask in diphtheria, they will ask in bacterial meningitis, they will ask in lobar pneumonia. These are the important things in which epidemiology is asked. Otherwise, don't break your head over it. Okay? Not so important. Then we are done with Staphylococcus. ठीक है? Pop-up हटाना, pop-up आ रहा है. Right. Then we have Streptococci. You all know it. Whenever there is only the determinants, I don't know, beta, what are you trying to ask? Please specify. Right. So, you know it. Whenever I say GPC, I talk about catalase. If it is catalase positive, it is the Staphylococcaceae family. If it is catalase negative, we come into the Streptococcaceae family. And amongst the Streptococci, we further look at the hemolysis on the blood agar. If it is beta hemolysis, it is beta hemolytic strep. If it is alpha hemolysis, it is your Virulence or pneumococcus. If it is gamma or no hemolysis, it is Enterococcus. You know this. So, who are we talking about in skin and soft tissue infections? We're talking about the beta hemolytic strep. Okay. What does pneumococcus cause? It causes bacterial meningitis and lobar pneumonia. What does Enterococcus cause? It causes abdominal infections and UTIs. What does Virulence cause? Dental plaques and subacute bacterial endocarditis done in bloodstream infections, FARRE. Okay. So, we are left with two streptococci, which are the beta hemolytic guys. Group A beta hemolytic and group B beta hemolytic. So, we are first going to start with group A. So, what are streptococci? They are also GPC. They are arranged in chains. It all depends upon the plane of division. You know it, right? These are facultative anaerobes, and whereas Peptostreptococcus is an obligate anaerobe, but we are not going to talk about it, right? So, based on the hemolysis on the blood agar, we are going to classify. Alpha is greenish discoloration shown by Virulence and pneumonia. Beta is complete hemolysis shown by group A and group B, and gamma is no hemolysis, which is shown by Enterococcus, right? Further, the group A and group B are classified based on the Griffith typing, based on the M protein only in the beta hemolytic strains. So, only the beta hemolytic strains are further classified based on Griffith typing. Who has given group A and group B? It is the Lansfield grouping, which is the C carbohydrate antigen on the cell wall. So, Streptococcus is beta hemolytic. Now, I look at the C carbohydrate antigen. If it is the A type, it becomes group A strep, then it becomes group B strep, and so on, right? So, amongst your group A strep, which is also called as the gas, what is the name? Streptococcus pyogenes. Now, pyogenes is called as pus producing. Pyo means pus producing. So, it is pus producing Streptococcus. It has, of course, a thick peptidoglycan. Why? Because it is a gram-positive bacterium. It, of course, has the lipotecoic acid. Why? Because it's a gram-positive bacterium. Then what is the specific cell wall factor of it? It is the C carbohydrate antigen, which is making it a group A. That is why, because it has become group A strep. Then the most important is the M protein. This M protein is the most important. This M protein inhibits complement mediated phagocytosis, and this is responsible for molecular mimicry. That is why this guy right now will cause a suppurative or pus producing infection, such as a sore throat, such as necrotizing fasciitis, such as scarlet fever. Later on, it will lead to non-suppurative complications such as acute rheumatic fever, such as post-streptococcal glomerulonephritis, because it produces this M protein, right? Then it also has a capsule. Does it? It can have a hyaluronic acid capsule, which is responsible to bind to the pharyngeal receptors. So, you know, this is in fact a very famous MCQ, that the binding protein on Streptococcus is actually the hyaluronic acid capsule. Toxins, of course, see, this is what? This is a beta hemolytic strep, right? So the most important toxin that it is going to produce is the hemolysin toxin, right? If it is a hemolysin toxin being produced by Streptococcus, can I call it streptolysin? Of course. So there are two streptolysins, streptolysin O and streptolysin S, which is produced by your Streptococcus. I'm good. I hope you're good too. Okay? So S stands for serum soluble and O stands for oxygen labile. Right? So streptolysin S is the serum soluble one, and streptolysin O is the oxygen labile one. Which is the most important antigen out of these? It is streptolysin O, because against this streptolysin O we will detect the anti-streptolysin O antibodies inside the patient if we want to diagnose the post-streptococcal non-suppurative complications, है ना? Because today if you are having a sore throat, the bacterium is sitting in your throat. I can take a throat swab and I can grow it in culture. 3 months later, when you have a glomerulonephritis, then that bacteria is nowhere to be found. At that time, if I have to retrospectively find out whether in the past you had streptococcal infection or not, I can detect antibodies in your blood. Which are that specific antibodies which will tell the tale about it? It is these streptolysin O, antibodies formed against streptolysin O. That is why anti-streptolysin O antibodies, which is the ASO titers, is what we measure. So what is the most important thing about group A Streptococcus? It is group A because of the C carbohydrate antigen. It is beta hemolytic, so of course it is going to produce hemolysins. So hemolysins are of two types, streptolysin O and streptolysin S. Streptolysin S means serum soluble and streptolysin O means oxygen labile. This O is the most important because we are detecting the thank you so much, because we are detecting the anti-streptolysin O antibodies. So there is nothing to ratify. Everything makes sense, you know. There is a reason that we study certain characteristics about a certain bacterium, because that is its virulence factor. And the same thing we use for lab diagnosis. So it is all connected. ठीक है. अब streptococcal pyrogenic exotoxin E is what is released by it. Guys, please pay attention to the little words. The name of the bacterium is Streptococcal pyogenes. Pyogenes is the name of the bacterium. The toxin that it is producing is Streptococcal pyrogenic exotoxin. ठीक है ना? बहुत सारे बच्चे खुद में कंफ्यूज हो जाते हैं कि toxin is pyrogenic but the bacterium is pyogenes. Bacterium is pyogenes, right? Why is the toxin pyrogenic? Because toxin is leading to fever. And which fever? S pyro, S fever. So कौन सा fever? Scarlet fever, right? This is the exotoxin which produces scarlet fever. Simple. चलो जी, streptococcal pyrogenic exotoxin causes scarlet fever, causes necrotizing fasciitis, and this is the one which is also responsible for causing toxic shock syndrome associated with streptococcus. So two guys can produce toxic shock syndrome. There is Staphylococcus with the toxic shock syndrome toxin, and there is Streptococcus with the स्ट्रेप्टोकोकल पायरोजेनिक एक्सोटॉक्सिन. ओके, इसका टॉक्सिक शॉक सिंड्रोम का टॉक्सिन है SPE, अलग है. ठीक है. ओके, एंजाइम्स क्या होंगे? स्ट्रेप्टोकाइनेज. व्हाट विल स्ट्रेप्टोकाइनेज डू? इट विल ब्रेक द फिब्रिन क्लॉट्स, डीएनएज, हाइलुरोनिडेज, प्रोटीएज, न्यूक्लियस. Nothing new. What is Streptococcus doing? Skin and soft tissue infection, but spreading type. So if it has to spread onto your skin, it also has to break the DNA, break the nuclease, produce protease, all of those enzymes which commonly make sense to your brain, even if you think about it. Then what will the body do? Body will produce clot barriers. So it has to break these clot barriers to spread further and further into your skin. So to break these clot barriers, I will tell you, Shreyas, wait. To break these clot barriers, it will produce streptokinase. So streptokinase is the clot bursting enzyme. So can you tell me about the cell wall? Yes, ma'am, I can tell. It is gram positive, so it will have the features common to gram positive. Thick peptidoglycan, lipoteichoic acid. Other than that, Streptococcus always has this M-shaped crown on its head. What is this M-shaped crown? M protein. The most important protein about Streptococcus, right? Then you have to write about toxins. It is a beta hemolytic strep, so it will produce a hemolysin. S and O, and we have seen the importance of O. Then of course it will produce certain toxins, enzymes and toxins. Other toxin is streptococcal pyrogenic exotoxin, SPE. ठीक है? Beta, please contact me on my social media. Right now, this is not the correct place to answer this question in the class because we're focused on second year MBBS students and getting their syllabus done. All right. I have just answered you chemical whatever, mechanical whatever your name is. So please refer to it. Hanji, Shreyas, you're asking what is exotoxins and endotoxins. Simple sa idea hai. You know, I have also covered this in general bacteriology, general microFARRE. Simply think of exotoxins like missiles or arrows and think of endotoxins as suicide bombs. Okay. So, and whenever you think of arrows, you think of Avatar, the movie Avatar. So, Avatar people had blue colored skins. So, the exotoxins are released mainly by the gram positive bacteria. And the suicide bomb is only and only worn by the negative people, which is the gram negative bacterium. Okay? So, exotoxin is gram positive, endotoxin is gram negative. Endotoxin is like a strapped suicide bomb. So, what will happen? To kill the other bacterium, it has to burst itself. So, for releasing endotoxin, a bacterium lyses its own cell. And why does it have to do that? Because in the general microbiology FARRE, we had read that the gram negative bacterium have the lipopolysaccharide layer or the LPS layer in their cell wall. The LPS ka mnemonic was LPS, where L would stand for lipid A. This lipid A is what is the endotoxin of bacterium. So, if the bacteria has to release endotoxin, it has to burst itself. That is endotoxins. And if a bacteria has to release exotoxin, it will shoot these tiny little arrows which have a very strong aim. So, the exotoxins have tissue specificity. For releasing exotoxin, a bacteria does not has to die by itself. It is simply sit and release these arrows outside. These arrows will go and hit specific tissue targets in your body. So, if it's a neurotoxin, it will specifically hit neurons. If it's an enterotoxin, it will specifically hit your gut. If it's a tissue specific cytotoxin, it will specifically go and attack the cells of that particular body organ. So, that is an exotoxin, and that's the difference with endotoxin. So, when I'm talking about these gram positive bacteria and their toxins, of course, I am talking about exotoxins. So, even the streptococcal pyrogenic exotoxin is a exotoxin. Even the toxic shock syndrome toxin of staph is a exotoxin. Even the enterotoxin of staph aureus is a exotoxin. These are all exotoxins because only gram negatives have the N sound. So, only they will produce the endotoxin which has the N sound. Okay, I hope that cleared your question. Beta, just type my name on Instagram and you will find me there. So, that is where you can contact me. Chalo ji. Next is clinical manifestations of Streptococcus. So, we went off topic for a little bit. Let's come back to it. We were discussing Streptococcus. Streptococcus ka we have seen the GPC in chains. We have seen the different hemolysins. We have seen the virulence factors including cell wall, toxins and enzymes. Now, toxic shock syndrome is present in complement mechanism. I don't understand your question, Mitul. Yes, you're welcome, Shreyas. Chalo. Then it will cause, like I said, two types of infections, suppurative and non-suppurative. What is suppurative? Suppurative is pus producing. What is non-suppurative? Non-pus producing. Suppurative infections are it is a most common cause of bacterial pharyngitis or sore throat, also referred to as strep throat or sore throat. Okay? So, what will you see over here? You will see pus points in the tonsils, pus points in the pharynx. So, there is pus producing pharyngitis, tonsillitis or sore throat which is produced by Streptococcus. Skin and soft tissue infections, it produces impetigo. In impetigo, you see these honeycomb crustings. Cellulitis is infection of the subcutaneous plane. Erysipelas, wherein the lymphatics, the superficial lymphatics are involved. So, it gives the pudgy orange appearance. Okay. Then there is the necrotizing fasciitis, and it is this disease which has earned the bacterium the name of flesh-eating bacteria. So, because it causes necrotizing fasciitis and it does not cause it alone. So necrotizing fasciitis is gangrene, okay? It is necrosis of the fascia. So it does not happen alone. It happens along with certain other anaerobes. So your group A Streptococcus along with some anaerobes, it will lead to necrotizing fasciitis, which is a deep life-threatening skin and soft tissue infection triggered by, of course, the streptococcal pyrogenic exotoxin. It is associated with trauma, surgery, etc. ठीक है? Difference between amoebic and bacillary dysentery. Okay, guys, this controversy has already been explained in the class. Please refer to the latest edition books. That correction is being made in the notes. However, we are discussing skin and soft tissue right now, guys. So let's focus on that itself. This controversy we can discuss in the GIT. All right. हाँ जी. So necrotizing ये हो गया हमारा. एनारोब्स के साथ मिलके नेक्रोटाइजिंग फेशियाइटिस करेगा और क्या करेगा ये? That is the reason that it is called as flesh eating bacterium. It is called as flesh eating bacterium. ठीक है, चलो जी, डन. सो क्या क्या, व्हाट इज इट डूइंग इन द स्किन? इट इज कॉजिंग द लोकलाइज्ड इन्फेक्शंस, इट इज कॉजिंग स्प्रेडिंग इन्फेक्शंस, एंड इट इज ऑल्सो कॉजिंग योर necrotizing fasciitis, which is called as flesh eating bacterium. Then you have non-suppurative complications. Non-suppurative complications में आपका आता है rheumatic fever, rheumatic heart disease, post-streptococcal glomerulonephritis, and you know what is the reason of it? It is the reason of cross-reacting antibodies against the M protein, right? So you know that antibodies against the M protein, they cross-react. They cross-react with the antigens present on the heart, kidneys, nails, and the skin and the brain. So it causes acute rheumatic fever, post-streptococcal glomerulonephritis, and something called as PANDAS. What is PANDAS? Pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Okay, my students tend to love to remember this full form somehow, because the weirder the name and the weirder the full form, the students love it even more to remember that. So that is PANDAS. ठीक है? So suppurative complications हमने देख लिए इसके. क्या क्या स्किन में हमने देखा? सेल्यूलाइटिस, एरिसिपेलास, इम्पेटिगो. Most important, necrotizing fasciitis. Then non-suppurative is rheumatic fever, post-streptococcal glomerulonephritis, and PANDAS. It also causes what? It also causes your scarlet fever, है ना? Scarlet fever in the children, जिसमें you have the strawberry tongue and circumoral pallor, etc. Right? So what we can do? We can write here scarlet fever separately, because that can be a separate short note. है ना? Separate short note. So what happens in scarlet fever? Scarlet fever is also because of streptococcal pyrogenic exotoxin, right? So now this SPE itself has everything that you need to know about this. It's a fever. So of course there's going to be fever plus lymphadenopathy plus sore throat in this patient. Right, because it is because of streptococcus, so sore throat will be there. All of this is going to be there. Then you have SP. SP stands for sandpaper rash. Sandpaper rash. Okay. Then you have P. P stands for Pastia's lines. Pastia's line. Pastia's lines. Then you have S. S stands for strawberry tongue. Strawberry tongue. These are the features of scarlet fever. And of course, caused by group A Streptococcus, lab diagnosis common, treatment common. Right? When we will write about, yes, just simply explain in a single line, Ashi. What is there to explain? You're writing Erysipelas, just write pudy orange in front of that. You're writing Impetigo, just write honeycomb crusting in front of them. You're writing cellulitis, just write subcutaneous infection. Just one word is enough to explain it. But if you're writing, highlight it so that it's a complete answer now. Now all knowledge has been delivered to the examiner nicely. ठीक है? Alright. Lab diagnosis में pus collect करेंगे या throat swab collect करेंगे. If it is causing sore throat, we will collect the throat swab. Of course, first thing you do in all bacteria is gram staining. So you are going to see gram positive cocci in chains. Then you will have some culture requirements. It requires enriched media. It will not grow on basal media. It's a fastidious organism. It wants 5% CO2. It wants enriched medium. Okay. So you will give it blood agar, on which it will will show me the pinpoint colonies with the wide zone of beta hemolysis. Yes, so you will draw these wide zone of beta hemolysis nicely. Simply draw these pinpoint white colored colonies and then simply draw this very wide zone of beta hemolysis around each one of them. ठीक है, हो गया. Then you have selective media for it. बहुत ही important है तुम्हारा selective media, crystal violet agar. Crystal violet agar or CVA. CVA inhibits Staphylococcus and selectively allows Streptococcus to grow. So what was the selective medium for staph? MSA, mannitol salt agar. What is the selective medium for Streptococcus? It is CVA, crystal violet agar. Then Todd Hewitt broth. Todd Hewitt broth is used for enrichment broth. It is used as enrichment broth. So Todd Hewitt broth. Even if you can't remember the full form in exam, just write THB. THB. So even if you can't remember Todd Hewitt, just write THB and that is good to go. डन हो गया. अच्छा, नाउ लेट्स टॉक अबाउट आइडेंटिफिकेशन टेस्ट. क्या आइडेंटिफिकेशन टेस्ट करेंगे? कैटलेज. क्या होगा कैटलेज? has to be negative, na? Has to be negative. Otherwise, it will fall out of the Streptococcaceae family only. So, catalase as a rule is going to be negative. Then we have two tests to differentiate between group A and group B. It is CAMP test and bacitracin. So, my students will remember the mnemonic for bacitracin is ABS. So, you know that group A is bacitracin sensitive. So, it is going to be bacitracin sensitive. And CAMP test ka mnemonic hota hai boot camp. So, boot camp is telling you that group B is CAMP positive. So, this guy is going to be CAMP test negative. So, you can simply draw a blood agar. Simply draw a blood agar, right? And just say that, okay, in the middle of this blood agar, I have placed a disc of bacitracin. So, this guy, group A, is going to show me this zone of inhibition around this disc. This is a positive bacitracin test. What is this? This is positive. So, this is bacitracin sensitive. This is your group A Streptococcus. Then you will simply draw the CAMP test also. Very easy to draw. I always tell my students, whenever you want to draw CAMP test, draw a nice big blood agar plate. In the blood agar plate, in the center, you will put a streak of Staph aureus. Here is the streak of Staph aureus. And Staph aureus has its own nice beta hemolysis. Own nice zone of beta hemolysis. Then perpendicular to it, you put a streak of your group A Streptococcus and a group B Streptococcus. Both of these will also have their nice zones of beta hemolysis, right? This is how you draw a CAMP test. Then what happens? What was the mnemonic? Boot camp. Boot camp. So, I have to draw CAMP positivity in group B. What does CAMP positivity look like? That there is going to be an enhanced zone of beta hemolysis with the group B Streptococcus. So, you see this arrowhead zone of enhancement. So, you will label this one as group B, group B Streptococcus. And this, of course, the negative one becomes group A Streptococcus. Group A Streptococcus is CAMP negative, whereas group B is CAMP positive, wherein you see this enhanced zone of beta hemolysis. Enhanced arrowhead zone of beta hemolysis. Done. बन जाएगा exam में. If I can draw it quickly, you can draw it quickly. Just draw these things quickly in the exams. So, you will talk about the CAMP test also. Then you have ASO titers, because to detect past infection, you will do ASO titers and you will also do anti-DNase B antibodies test. Anti-DNase B antibody test. ठीक है ना? Done हो गया. Then what about group B? I always tell the students, group B means babies. So, B stands for babies. So, this is the one which is going to cause neonatal meningitis, neonatal sepsis, and B also stands for birth canal. So, this is where it is present normally. Then B is not B. So, B is A. So, group B Streptococcus is Streptococcus A galacti, है ना? कहाँ पे है? बर्थ कैनाल में. वहाँ से किसको मिला? बेबीज को. It is a part of the normal flora of the female genital tract and it is important pathogen in neonatal medicine leading to neonatal sepsis and neonatal meningitis and pneumonias. ठीक है? That is what it causes. कैसे differentiate करेंगे? ऐसे ही करेंगे. Catalase negative होगा, bacitracin resistant होगा और CAMP test positive होगा. So, it is going to be bacitracin resistant and CAMP test positive, and of course, you can show the enhanced arrowhead zone of beta hemolysis, which is the CAMP positive test. ठीक है, done and done. Two basic but supremely important groups of bacteria done. We have covered almost everything about them. This is going to help you in your practicals. This is going to help you in your theory exams. All right. So if you're good to go, if you're still with me, let's move ahead. Yes. And we will talk about leprosy, the most important. Before that, you have to check out the lecture on anthrax and gas gangrene. Okay. So I've told you Staphylococcus, Streptococcus we've done today. Anthrax and gas gangrene I've already covered in the last minute bonus lecture of the 2025 FARRE. And now we are going to talk about leprosy and actinomyces, which are two special bacteria which we are going to discuss. So leprosy is of course caused by Mycobacterium leprae, right? Mycobacterium leprae. Thank you. Okay. You're welcome. No, they are not important. S, E, C, D, F, G are not at all important. I mean, even your MD students are not reading so much. So don't worry about group C, D. You know that group D is nothing but Enterococcus. Yes. So group D itself is Enterococcus. So you are reading group D. C, F, G are not important for you at all. ठीक है, चलो जी, हम बात करें माइकोबैक्टीरियम लेप्री. माइकोबैक्टीरियम लेप्री. So my students would remember the mnemonic. Mr. Rick Cox has, leper Rick Cox has chlamydia, so he can't leave the house. So they know that leprosy is a obligate intracellular bacteria. It is a bacterium which cannot grow outside the host cell. So it is a bacterium which will not grow on any artificial culture medium. So the only place wherein you can grow leprosy bacteria is in an animal model. So either it grows in the foot pad of mouse or it grows in the 9-banded armadillo. Nowhere else. So it's an uncultivable mycobacterium, okay, obligate intracellular. It is called as Hansen's disease, leprosy, because it was discovered by Hansen's. That is why this bacterium is also called as Hansen's bacillus. Okay, a few universities, what they are doing, they are just simply giving you these fancy names. So instead of writing a long question in the short notes, they will just write Hansen's bacillus, Koch's bacillus, Brill-Zinsser disease. So that is how they're giving. So you please pay attention to these special names also. Okay. So what can I do is I can release a list also of these special names so that you immediately can revise them very, very quickly. So I'll do that. All right. So leprosy, Hansen's disease, is what it is called as. Causative agent is Mycobacterium leprae. Who is this guy? It is an acid-fast bacillus. Who will tell me why is it an acid-fast bacillus? Because at the end of the day, this is a mycobacterium. So all mycobacteria share the common feature. All mycobacteria have mycolic acid in their cell wall. All mycobacteria are obligate aerobes and all mycobacteria are acid fast, irrespective of whether you're talking about Mycobacterium TB or you're talking about Mycobacterium leprae or you're talking about non-tubercular mycobacteria. All of them at the end of the day are acid fast, all of them are obligate aerobes, all of them have mycolic acid in their cell wall. Okay? So this is also acid fast, but it is acid fast with 5% H2SO4. So what is the modification of Zeden used? That instead of 25% like we do with TB, here we use 5% sulfuric acid or H2SO4. It is an obligate intracellular bacterium and it is an obligate aerobe. So all of these are the common features of all mycobacteria. You know it. It has failed the Koch's postulates. Why? Because it is uncultivable bacteria. So Koch's postulates ke liye you had to be able to grow the organism on a culture plate. So here it cannot be grown on artificial media. Then it loves the cold temperature. It loves the cold temperature so much that it affects your skin and peripheral nerves, testes. And it spares the warmer areas like axilla and groin. So this is telling you that even the features are going to come in these places. So you will have the neuropathies or the tingling sensations or the nerve involvement. Then the skin involvement, the lesions are going to come on the face. They are going to, the bacteria you're going to find maximum in the extremities, in the earlobes, in all of these areas, a lot more than your axilla, groin and the warmer areas of the body. So that is what it is going to do. You're going to find it in the tip of the nose, you're going to find it in the earlobe, you're going to find in the tip of the fingers. All of these colder areas of the body is where you will find him. You will find him in the nerves. Okay. Then it has a very long incubation period. It almost takes 1 year to grow this bacterium and it is, the generation time is 20 days. So my students remember it. What is the generation time? 20, 20, 20. So it is 20 hours 20 minutes for E. coli, 20 hours for TB, and 20 days for leprae. So if one bacterium to do the binary fission of dividing from 1 to 2 is taking 20 days, then to form 10 to the power 8 bacterium to give me one single colony will obviously take years to grow. Okay? So it is uncultivable. What is the natural reservoir? It is the 9-banded armadillo. The 9-banded armadillo, that is why in here we are able to grow him, and from whom we get the disease. Okay? तो आप बना दोगे एक सिंपल सा डायग्राम. You will make red colored bacteria telling that this is an acid fast bacilli, and the feature of it is that it is an obligate intracellular bacterium, right? So where will you find these acid fast guys? You will find them deep inside the macrophages. So you will find a macrophage, yes, 20. So you will find a macrophage which is foamy. Why is it foamy? Because it is totally filled with your lepra cells or lepra bacilli. Okay? So this macrophage is called as Virchow cell, foamy cell, globi, lepra cell. Why? Because one single macrophage is going to be totally filled, jam-packed with lots and lots of lepra bacteria, meaning lots and lots of acid phi bacilli. That is what they are making the cigar or the globi shape structures. This is very, very characteristic of leprae. That is how you differentiate. Mycobacterium TB will be found in some amount, but lepra will be found in khach bhar ke, okay? It is going to totally fill up the macrophage, and this totally filled macrophage with the acid fast bacilli is what I call as a foamy macrophage or a Virchow cell or a lepra cell. Okay, Virchow cell, lepra cell, foamy macrophage, globi cell, whatever you want to call it. ठीक है ना? तो clinical classification is very, very important. There are spectrums. Leprosy always exists in spectrums of clinical features. So there are some and that depends upon the cell-mediated immunity of the person. See, it's an obligate intracellular bacteria. So the bacteria is going to hide inside my own body cells. It is going to hide inside my own body's macrophages. So antibodies are not going to help in its killing. It has to be killed by cellular cytotoxicity. The only way to kill this bacterium is to kill the cell. So to kill the cell, we need more cells. So the prognosis of the disease or how bad or good the disease is going to behave in a person will depend upon the status of the cell mediated immunity of that person. So if the cell mediated immunity of the person is good, then that immunity is able to control the bacterium a little bit, right? So a person with good cell mediated immunity will be able to control the bacterium. So bacteria will not grow a lot. So that will be a paucibacillary kind of a disease, and we call that as paucibacillary leprosy. What is paucibacillary? Less bacteria in the person. So if the amount of bacteria is less, it will cause less lesions, it will involve less nerves. So in paucibacillary, there are less than 5 skin lesions, there are less 0 to 1 nerves involved. However, whatever nerves are getting involved, they are getting involved early in the disease. Okay, we'll come on to that. Secondly, when I do a slit skin smear, so what is the sample which is taken for lepra bacteria? Slit skin smear. Why? Because I will find it in these peripheries in the skin. So we will slit the skin, take out the sample, and then look for the lepra bacilli because it loves the cold temperature, it lives in these skin areas. Okay. So paucibacillary leprosy mein, there is going to be less lesions in the person. Overall in the body, we will find less than 5 lesions. Overall, there will be less than 1 nerve involved in the person. And also when we do the slit skin smear, we will find that all the samples are going to be negative. So we will not be able to detect the bacterium only in the slit skin smear. So very difficult to detect paucibacillary leprosy. What about multibacillary leprosy? Over here, of course, there are multiple bacteria. So of course, the cell mediated immunity of the person is weak. The immunity is not able to control the bacteria. So bacteria is proliferating like anything. So it is leading to lots of skin lesions. So there are more than 5 skin lesions. Lot many nerves are involved, more than 1 nerve involved, and also slit skin smear is going to be positive for these people. So the 2 ways to classify is paucibacillary and multibacillary. Another is the clinical classification, which is the Ridley-Joplin and the Indian classification. So first we'll talk Ridley-Joplin. Ridley-Joplin is easy. See, whenever a person's immunity is good, it is the paucibacillary leprosy, which is also called as tuberculoid type of leprosy. Okay? Why? Because when the person's cell-mediated immunity is good, that immune cells will come and try to control the bacterium. So they will create a granuloma type formation, which looks like the tuberculous, tuberculoma. Okay. So Ridley-Joplin said that on the one spectrum, there is the tuberculoid leprosy. Tuberculoid leprosy. And on the other end of the spectrum, there is the lepromatous leprosy. So what is tuberculoid leprosy? It is the paucibacillary leprosy. What is lepromatous leprosy? It is the multibacillary leprosy. Okay. Then he said in the right in the middle, there is something which is called as borderline leprosy. Okay, borderline leprosy or borderline. Then the one in between these is borderline tuberculoid. The one in between these is borderline lepromatous. Okay. So according to Ridley-Joplin, you have tuberculoid leprosy, borderline tuberculoid leprosy, borderline lepromatous leprosy, and lepromatous leprosy. Then came the Indians. Indians don't like to follow all these foreigner rules. Indians create their own rules. They stuck to two things. They said, okay, on one end I will keep lepromatous, on the other end, far end, I will keep tuberculoid. That is fine. We also kept tuberculoid and lepromatous on the two ends. In the middle, we said that, okay, one is borderline leprosy, and then there is indeterminate. We don't know what this is. And then finally, we have the pure neuritic type. So Indian classification is a little different. You have borderline, intermediate, indeterminate, and pure neuritic in between lepromatous and tuberculoid. Whereas Ridley-Joplin is quite easy. TLBT, BBBL, LL. Okay. So you will have to must write about these classifications. Both of these are very, very important. Right. So what is it depending upon? What is deciding that this person will come with paucibacillary or multibacillary? What is deciding that this person will fall into this clinical spectrum of the disease? The immunity of the person is deciding it. Yes. So it is the immunity which is deciding. So if it is a good cell mediated immunity, high CMI, it will present as tuberculoid leprosy. If it is a low CMI, it will present as lepromatous leprosy. Okay. So high CMI, which is because of what? The T helper 1 response, which will release the interleukins and interferons. They will call. What does interleukin 2 do? All of this is immunology recap which is happening. Interleukin 2 will go and activate the cytotoxic T cells. The interferon gamma will go and they will call the macrophages. These macrophages will convert into activated macrophages, which will turn into epithelioid cells, which will turn into Langerhans cells. What do you have with yourself at the end of the day? Granuloma formation. So that is why it is the tuberculoid type of leprosy. The activated macrophages, they lead to granuloma formation. And what does this granuloma do? It controls the disease. It limits the infection. It controls the disease. So therefore, you get few asymmetric hypopigmented macules with a well-defined raised margins and a central clearing. So you draw this. In the person's skin, you will have white hypopigmented patches which are going to be surrounded by raised margins. Okay. And then the nerve involvement is going to be less. But whatever nerve is involved is going to be involved as an early hypoesthesia. Okay, early hypoesthesia. However, the prognosis in this person is definitely going to be a good prognosis because the person has high cell-mediated immunity. Right. So what are the features of tuberculoid leprosy? There is the hypopigmented patches with the raised margins, and there is the nerve thickenings and early hypoesthesias. What are the features of lepromatous leprosy? Therein, there is high bacillary load. This is multibacillary and there are numerous symmetrical skin lesions. It leads to something which is called as the leonine facies. What happens in leonine facies? You have nodules in the skin, you have nose deformities, no eyebrows, corneal scarring. So all of these bad things happen to the patient. Nodular lesions, loss of eyebrows, saddle nose. The nerve involvement, however late, is going to be symmetrical and it will involve a lot more nerves and the prognosis is going to be poor. So what all will you write about in tuberculoid and leprobatus? You will write about the cell-mediated immunity, you will write about the T helper response, you will talk about the skin lesions, you will talk about the nerve involvement, and you will talk about prognosis. These are the 5 headings in which you differentiate. You will talk about the cell-mediated immunity, you will talk about the T helper cell response, you will talk about the skin lesions, which is leonine facies here and hypopigmented patch here. You will talk about the nerve involvement. And number 5, you will talk about the prognosis. These are the 5 headings in which you will make this differences table. And like I always tell my students, whenever you are reading a chapter, whenever you are reading a topic, ask yourself these 3 questions. Can I draw 3 diagrams from this topic? Can I draw at least 1 flow chart? Can I draw at least 1 comparison table in this topic? Right? So from Streptococcus, you could draw the comparison table between group A and group B. And in leprosy, you can draw the comparison table between tuberculoid and lepromatous leprosy or paucibacillary and multibacillary leprosy. Okay? So make sure you're drawing these differences tables. All right? Done and done. So what are the complications? Now you have 2 important things. Don't confuse lepra reaction and your lepromin test reactions. Okay, they are 2 different things. Before that, we have to talk about complications. So, a lepra reaction is in fact a complication of the leprosy disease, right? So, leprosy will lead to either chronic complications or it will lead to some acute complications. Chronic complications mein kya hoga? Like I said, there is nerve involvement. So, there is going to be hypoesthesia. Person is not going to feel anything. Is not going to feel pain, not going to feel heat. So, what will happen ultimately? Even if there is any kind of a trauma, the person is not able to pay attention to it. Eventually, it can lead to loss of those parts. So, corneal ulcer, saddle nose and extremities ki deformity. So, there is wrist drop, loss of digits. Why does this happen? Because of the nerve involvement. This is a complication. The whole nodular face has become deformed. The nose becomes deformed. The extremities, they are lost. Why? Because of the nerve involvement, which is a part of a late stage of the disease. Okay, so it is a late complication. Then you have a complication which is called as lepra reaction. What is lepra reaction? It is an acute inflammatory response, like an allergic response to the disease. So it's an acute complication. Lepra reaction is not lepromin test. Guys, listen to me very carefully. This is something students confuse. Lepra reaction is not the injection you're giving and looking at. It is not like Montu's test. It is not lepromin test. Lepra reaction is a complication of a disease. Okay, it's an acute complication. What is it? There can be type 1 lepra reaction and type 2 lepra reaction. What is the way to remember? Very, very easy to remember. The sum total should be 5. So, these are some type of hypersensitivity reactions. So, lepra type 1 reaction is actually 1 plus 4 is 5 is actually a type 4 hypersensitivity reaction. And lepra reaction 2 is actually a 3 plus 2 is 5 type 3 hypersensitivity reaction. So, type 4 is of course delayed type hypersensitivity, type 3 is of course immune complex mediated deposition, right? So, this is type 4, it is seen in borderline lepromatous cases and old lesions only become ulcerated. So, what happens in lepra reaction 1? There are no new lesions which are formed. The old lesion itself will ulcerate. It is a delayed type hypersensitivity response. Whereas in type 2 lepra reaction or which is type 3 hypersensitivity, you see it in lepromatous cases. So, it occurs after you start the treatment and you see new lesions and new organs getting involved. So, even if they ask erythema nodosum, that is a part of lepra reaction 2 now, okay, not 3. हो गया. Then you have lab diagnosis. क्या specimen लेंगे? Like I had said, slit skin smear. Slit skin smear is the specimen you will take from 6 sites on the body. Earlobes, forehead, cheek, chin and buttocks. Okay. Earlobes, forehead, cheek, chin and buttocks. So just do this action and you will remember. Earlobe, forehead, cheek, chin and buttocks. These are the places from which you will take the 6 slit skin samples. Along with that, you can ask the person to blow their nose and send you the sample because it loves to live in the anterior nose. Then you will of course do the microscopy, for which you will use the 5% H2SO4 modification of the Zn stain, and you will see the acid-fast bacilli. What kind of acid-fast bacilli? You will see acid-fast bacilli which are cigar or globi arranged in the foamy macrophages, also called as the lepra cell. So you will have one macrophage totally filled with the acid-fast bacilli. So just looking at this slide is not enough, okay? You have taken the slit skin smear samples, you have put it onto a slide, you have done the 5% H2SO4 Zn staining, and then no, it is not necessary to write the slit skin smear procedure. However, the procedure is one line long. Okay, I mean, what all are you doing? You're simply making a slit and you're collecting the pus from the base. It is a one line short, procedure. So you need not, you don't have to, be a miser. If time is allowing, you have fast handwriting, write it by all means. But otherwise, you can simply just say that 6 slit skin smears are needed. Okay? Chalo ji. Then I was saying that just looking at the acid-fast bacilli is not enough. Okay, you have to then do a index. So for TB, you would do the RNTCP guidelines. For this, you have to detect the bacteriological index and you have to detect the morphological index. ठीक है? क्या-क्या ढूंढना है आपको? Bacteriological index and morphological index. What does it mean? Bacteriological index is telling you the density of bacilli in the smear, the total number of bacteria present, the total number of bacilli present, and then morphological index is telling you how many of them are alive, meaning how many of them are uniformly stained. This is the difference, okay? So you have to discuss live versus dead bacteria. That is what you have to discuss. So bacteriological index is just telling you that you are seeing thousands or 10,000s or 5 crore bacteria, okay? Then morphological index is telling you how many of those are actually alive. So this morphological index is used to monitor the disease progression and response to treatment. Suppose if today you took the sample of a patient and the bacteriological index was 6. Then after 6 months of therapy, again you tested, it was still 6. But the morphological index has dropped down. Meaning, yes, the number of bacteria is still the same, but most of them are dead. So that is telling you that despite the morphological index not changing, patient is still, getting better. Okay. Next क्या है? Culture. You cannot grow it in artificial media. So where will you grow it? In the footpad of mouse, but only for research purpose, right? You can do the lepromine test, which is the Mitsuda reaction or the Fernandez reaction. Okay? So this lepromine test is just like the Montoux test. You're simply injecting the lepromine antigen and you're looking at the induration or the reaction formation. So there are two types of lepromine tests. One is the Mitsuda reaction, which is the late, and Fernandez reaction, which is early. How to remember? Just like ABCD. Just start writing ABCD. So ABCD, then you have EF, GHIJKL, LM. Okay. So the Fernandez reaction is an early reaction and the Mitsuda reaction is a late reaction. Okay. That is what you will write in lepromine test. Fernandez is early, Mitsuda is late. Mitsuda or late comes positive in 21 days. Okay. And if it is positive, it is telling you that it is a good prognosis and the person has a good cell-mediated immunity. Right? Then of course it is how does the transmission happen? Through inhalation of the bacilli by the droplet route. And who transmit this? The multibacillary kind of patients. So how will somebody get leprosy? From a multibacillary positive patient only. No other animal reservoirs, no other natural sources available. So if you come in contact with a lepromatous leprosy patient or a multibacillary leprosy patient, then through the respiratory droplets, you can acquire leprosy. What is the treatment? It is the multi-drug therapy which is given, wherein you give dapsone, rifampicin and clofazimine. If it is a paucibacillary patient, you give treatment only for 6 months. If it is a multibacillary patient, then you give treatment for 12 months. So that is why it is important to ascertain the paucibacillary and the multibacillary. Because A, if it is multibacillary, then he might have transmitted it to many people. B, the therapy needs to continue for a whole year. Whereas if it is paucibacillary, then it only needs to continue for 6 months. Why do we give multi-drug therapy? This is an important Viva question. Because of the increasing cases of drug resistance in tuberculosis. Okay. So just to prevent a day wherein there is resistance, and if at all there is some resistance, we should not find out after many months that the treatment was not working on this leprosy patient. Okay, so just to be safe, we give multi drug therapy. So we give triple whammy to the bacteria कि भाई इससे नहीं मरेगा तो इससे तो मरना पड़ेगा. That is dapsone, rifampicin and clofazimine given for 6 and 12 months respectively. Done. हो गया. वेरी इंपॉर्टेंट. ठीक है, लेप्रेसी बहुत ही जरूरी है. 2-3 चीजें ही याद रखनी है. सो आई ऑलवेज टेल माई स्टूडेंट्स दैट लेप्रेसी इज अ डिजीज ऑफ टूज, राइट. टू क्लासिफिकेशन. एक तो दो तरह के रिएक्शंस हो सकते हैं, ट्यूबरकुलॉइड एंड लेप्रोमेटिस. दो तरह की डिजीज हो सकती है, पॉसीबैसिलरी, मल्टीबैसिलरी. देयर कैन बी 2 टाइप्स ऑफ लेप्रा रिएक्शंस, लेप्रा रिएक्शन 1, लेप्रा रिएक्शन 2. There can be 2 types of lepromin tests, early and late, Mitsuda and Fernandez and Mitsuda. Then there can be 2 types of indices on the smear, bacteriological index and morphological index. So leprosy is a disease of टूज. ठीक है, दो तरह की हर चीज दो करके लिखनी है. सो दैट इज वन टॉपिक इन विच यू कैन मेक सो मेनी डिफरेंसेस टेबल. एंड इन फैक्ट लेप्रेसी इज अ टॉपिक इन विच द एग्जामिनर इज एक्सपेक्टिंग यू टू मेक डिफरेंसेस टेबल, because that is how the examiner has also learned that topic. Every microbiologist has understood leprosy in the form of comparison tables. So that is what they are expecting in your answer sheets also. ठीक है, so that is my 2 cents and pearl of advice. चलो जी, next आ गए हम एक्टिनोमाइसिटिस पे. What is actinomycetes? Whenever I add cities to anything, it becomes the family. Okay, it is a family which includes Actinomyces and Nocardia and Actinomadura and everything. So Actinomycetes is the family. In Actinomycetes, you have the bacterium whose name is Actinomyces. कहाँ चला गया? Actinomyces is the Actinomycetes. So you can have 2 types of Actinomycetes. You can have anaerobic Actinomycetes and you can have aerobic Actinomycetes, because mycetes is the family. ठीक है? Actino, what does actino means? Actino means rays of sun. Okay, so just the way the rays of sun, they come out like this, all of these bacteria are also long and filamentous and branching. So what is the Actinomycetes? These are filamentous gram-positive bacteria. They have a branching type of a growth. That is why they used to resemble fungi. They used to resemble mycelia or fungus. That is why we call them Actinomycetes. Mycetes means fungus. Okay, but these are true bacteria. This is not fungus. This is true bacteria, despite them looking like the fungus. Clinically, they form sinuses that discharge the granules. ठीक है? That is why whenever we read Madura foot, we say that Madura foot could be because of true fungus or true bacteria. If it is because of true fungus or eumycetoma, that is Madura mycosis. Where has that been covered? That has been covered in the mycosis lecture in 2025 FARRE. ठीक है? If it is because of bacteria, that is called as Actinomadura or Actinomycetes, which are these 2 guys. ठीक है? 2 groups हैं based on oxygen requirement, like I said, anaerobic guys and aerobic guys. The anaerobic Actinomycetes, they mainly involve actinomyces, okay, and actinomyces causes actinomycosis. It causes actinomycosis. Then you have the aerobic one, which is Nocardia and Actinomadura. ये क्या करता है? Actinomycetoma and infectious diseases, right? So what is the family? Actinomycetes. Okay, what are the possible diseases? Actinomycetoma or actinomycosis. ठीक है? Let me write it. What is the family? The family is Actinomycetes. ठीक है? Then it can cause diseases. So what are the diseases? Diseases are Actinomycosis or Actinomycetoma. Actinomycetoma. What are the bacteria? What are the bacteria involved? It is Actinomyces. And what is the bacteria involved here? Nocardia or Actinomadura. ठीक है? This guy is an anaerobe. These 2 are aerobes. Out of these, only this guy is acid fast with the 1% H2SO4, you remember? With the 1% H2SO4. Whereas the other two are non-acid fast. So this is non-acid fast and this is also non-acid fast. All of them are gram-positive branching filamentous bacteria. That is the thing. Okay. सब के सब हैं gram positive branching filamentous bacteria. So please don't get confused by all of these terminologies. Right? Actinomycetes is the family. The diseases caused are actinomycosis or actinomadura. The bacteria under these is the actinomyces and nocardia or actinomadura. ठीक है? Morphology देख ली हमने. Branching filamentous gram positive bacteria होते हैं. So you can make them. Then the disease that we are going to read now is actinomycosis. Who causes actinomycosis? Actinomyces israeli. Where does Actinomyces israeli live? It normally lives in your mouth. It is a part of the normal commensal flora of the mouth. Right? It leads to chronic granulomatous infection. In fact, it is the most misdiagnosed disease because the duration of the disease is many, many years. You will have somebody who will come that I have a lump in my jaw and this lump has been there for the past 10 years. So the most common diagnosis which comes to anybody's mind is carcinomas. Okay. That is why actinomyces is the most misdiagnosed disease. Always everybody tends to think that we are dealing with carcinoma, jabki we are dealing with a simple bacterial infection which is the lumpy jaw syndrome, also called as the wooden lump, because this lump in the jaw is hard like wood. It's a hardy wooden lump which has been there for a long, long time and it is painless. Okay. Clinical presentation, Actinomyces israeli is a part of the normal oral flora. So the mode of infection is endogenous, not exogenous. You get it? Why is it endogenous? Because it was normally present in my mouth only. And from my mouth only it has caused an infection of the jaw. So the source is endogenous. Okay. Clinical forms, most common clinical form is the cervicofacial actinomyces, which is called as the lumpy jaw syndrome. Okay. It involves the mouth and neck following dental caries or oral trauma. So it was present in the mouth. Then you went and got some dental procedure done. In that dental procedure, this actinomyces from your own mouth enters your bone, enters your jaw, leading to the lumpy jaw syndrome. Okay? Similarly, it can happen in the abdomen, wherein after surgery, it can go and affect the abdominal planes. Pelvic actinomycosis in prolonged IUD use, intrauterine device which is used by the females, in them it leads to pelvic actinomycosis, and disseminated forms where it can spread to the different bones. What is the diagnostic feature? There is going to be sulfur granules discharging from the sinuses. Okay, so all of these, they produce discharging sinuses with granules, right? All of these actinomycetes, what do they produce? They produce discharging sinuses with granules. So what are the granules produced in actinomycosis? Like I had said, actino is rays of sun, and sun is yellow colored. So that is why we have to, that is why the granules it produces is the yellow colored granules, because actinomyces is like the sun. It's like the sun. Okay, that is why it is yellow. So just please remember the sulfur granules which are yellow in color, they are produced from the discharging sinuses of the lumpy jaw. Okay? So lab diagnosis of actinomyces is gram stain. You do a gram stain, which is the Brown and Bren modification. Whenever we study gram stain, we study two modifications, Brown and Bren and Jensen. So Brown and Bren modification is done for actinomyces and Jensen's modification is done for gonorrhea. Okay. So this is, at what are we seeing in Brown and Bren? We are seeing the sun ray appearance of non-acid fast bacteria. Okay. Culture किस में करेंगे? Brain heart infusion blood agar. So I have a normal blood agar which I have enriched with the brain heart infusion, and we see the molar tooth colonies or the spider leg colonies. This is very, very important, right? So it causes lumpy jaw, and also on the agar plate it looks like the patient's teeth has only fallen onto the agar plate. Okay, so lumpy jaw and molar tooth. Just remember, always you think of actinomyces, just do this. Whenever you do this, you will remember what are we talking about? Lumpy jaw and molar tooth on the agar plate. Okay? Also, there can be the spider leg appearance. Then in the thioglycolate broth, it can give me the fluffy colonies which settle at the bottom of the tube. So actinomyces is actinomyces. It is obligate anaerobe, causes lumpy jaw syndrome, causes pelvic actinomyces in the IOD users. There is going to be the sulfur granule discharge. On brown and red modification, you see the sun ray appearance, and use on the BHI blood agar, you see the molar tooth colonies or the spider leg colonies, and in the thioglycolate broth, you see the fluffy growth at the bottom. Why is the fluffy growth coming? Because of the fungal-like mycelial structure. These are branching filamentous bacteria, na? So the growth that they produce looks like a fungus. So that fungal ball, even though it's not a true fungal ball, but this fluffy growth looks like a fungal ball in the thioglycolate broth, right? Guys, you will receive it at the end of the session, okay? Chalo. Then you have nocardia. Nocardia kya tha? It was aerobic. It is an obligate aerobe and it is found in the soil. Therefore, the mode of infection is going to be exogenous. So, you can make a differences table between actinomyces and nocardia. Actinomyces is anaerobe, nocardia is aerobe. Actinomyces is endogenous, nocardia is exogenous. Actinomyces is non-acid fast, nocardia is acid fast. So, at least these three things you can write in the differences table. Then clinical features are, it's an opportunistic pathogen. Actinomyces happens in immunocompetent people, whereas nocardia happens in immunocompromised people, right? It happens especially in the AIDS patients, leads to pulmonary disease, brain abscess, and localized skin infections also. So what was actinomyces doing? Leading to localized infections, lumpy jaw, pelvic. What is nocardia doing? Deep systemic infections, pneumonias, brain abscess. Lab diagnosis क्या है? Acid fast है कितने से? 1% H2SO4. Then the culture can be grown on the colonies. They look like wrinkled feathery colonies which are tough and adhere to the agar. Okay, so you have wrinkly tough colonies which don't break even if you put the loop on them. Selective technique which is used is the paraffin bait technique. Paraffin bait technique. So you will take some paraffin, you will put the clinical samples, and you will see that like a fish drawn to the worms, this nocardia comes there running to the paraffin. That is the paraffin bait technique, right? So if you are asked to make the differences table between actinomyces and nocardia, you can very easily make it now, I hope. This is anaerobe, this is aerobe, okay? This is non-acid fast, this is acid fast. This is endogenous, this is exogenous, right? This is this happens in immunocompetent. This happens in immunocompromised. Immunocompromised. Then this is spider leg, molar tooth, and fluffy ball. This here is paraffin bait and your tough, wrinkly colonies. These are the major differences between the two, and I hope that you can write them nicely. Next, देखो क्या है? Actinomadura, aerobic, non-acid fast, causes mycetoma. कैसे? Red and white granules. Cutaneous diphtheria, which can be because of Corynebacterium diphthery, causes pseudomembrane on the skin or the punched out lesions. Then you have some non-venereal treponemics, which is yaws, endemic syphilis, and pinta. I always tell my students to remember a crate of pints. So crate of pints will help you remember. Caratium is pinta. Endemic syphilis is endemicum, easy. Then the only one which remains is pertineo, that is yours. So yours is pertuni and pinta is caritium and endemic syphilis is Treponema endemicum. Then you have some NTMs, which is the swimmer's granuloma or the fish tank granuloma by Mycobacterium marinum, and the Burulli's ulcer by the Mycobacterium ulcerans. Yes, I hope you remember that marinum is a photochromogen, and ulcerans is a non-photochromogen. What's happening? Is a non-photochromogen. Okay, done and done, right? So now we're starting with viruses and we need to quickly talk about viruses. It's not necessary to read it, but these are some other causes of lesions. So they won't amount to much, but if they ask you in a short note, non-syphilitic causes of treponema, okay, if that is the question, then you can write about Yaws pinta and endemic syphilis. Right, if they're trying to make a difficult question paper, then they can give you, but this can definitely be asked in the MCQ. So you have those 10 to 20 MCQ questions in university exam, there it can definitely be asked, Yaws pinta and your endemic syphilis. चलो अब viral exanthem की बात करते हैं. Viral exanthems क्या हैं? These are the eruptive skin rashes commonly seen in the childhood. So these are also called as the exanthems of childhood. Okay. So now you have DNA and RNA viruses which can cause it. Amongst the DNA viruses, you have the herpes viridi which causes this, and you have the parvo and the papilloma viridi which causes these exanthems. Okay. Amongst the RNA viruses, you have measles, rubella and hand, foot, mouth disease causing Coxsackie virus. Okay. So you have in the herpes viridi, you have HSV and VZV which is responsible for causing these vesicular eruptions, where HSV causes multiple painful lesions and VZV causes chicken pox, hai na? Chicken pox. Whereas your HHV 6 and 7 causes the 6th disease and the others are not responsible for skin infections. So amongst the human herpes, you have human herpes 1, 2, 3 which is HSV 1, 2 and chicken pox, and you have the human herpes 6 and 7 which cause the 6th disease. Okay, 6th disease. HSV 1 is above the waist, HSV 2 is below the waist. So of course above the waist transmission of HSV 1 is through saliva and oral route. So what is the feature of these herpes viridae family? That they cause eruptions in the skin, and after that they ride on your nerves and they go and sit latent in one of the ganglions. Okay, so the HSV1 which happens above the waist is transmitted through the salivary route, goes and lives in your trigeminal ganglion. Whereas HSV2 which is below the waist goes and lives in the sacral ganglion. What are these? These are the places where they're going to go and sleep off. That is latency. They will sleep off for many years. Okay, this is latency. So HSV1 is above the waist, transmission is through salivary contact, they stay latent in the trigeminal ganglion and they lead to oral, cervical, ocular and CNS lesions. So you have seen the herpes labialis which is the oral cold sores, the hepatic gingivostomatitis, hepatic vitiligo in the dentist, all of this is herpes simplex 1. Whereas herpes simplex 2 is sexual route. It lives in the sacral root ganglion. So there is the genitourinary and of course neonatal infections. So anything which can be transmitted from the sexual route also causes infections in the neonates, because neonates pass through the birth canal and birth canal is the sexual contact route. Neurovirulence and drug resistance is there. Majorly both are more in HSV2 as compared to HSV1. Okay? So you will write about differences of HSV1 and 2, and amongst the diseases of HSV1 and 2, what will you write? HSV1 will cause, most common lesion is gingivostomatitis, herpetic gingivostomatitis, which is the most common recurrent lesion associated with HSV1. It is herpes labialis. Herpes labialis, which is also called as the cold sore. Cold sore. Then you have herpetic vitiligo. Herpetic vitiligo, which happens in the dentists, in the fingers. Herpes gladiatorum, which happens in wrestlers. All of this is herpes simplex 1. What happens in herpes simplex 2? Herpes simplex 2 leads to, in the CNS, it will cause mollaret meningitis. What is mollaret meningitis? Recurrent lymphocytic meningitis. The child will keep on presenting with recurrent episodes of meningitis. And every time there is meningitis, there is lymphocytosis. So it is recurrent lymphocytic meningitis, which is mollaret meningitis. This leads to genital herpes. Genital herpes, which is the painful multiple vesicular lesions. So what is the skin lesion associated in both? There is painful multiple vesicular lesions which occur in clusters. So they will be like a bunch together. Okay, this is the common feature of the skin lesions of both herpes simplex 1 as well as herpes simplex 2. Then you have varicella zoster virus. Varicella zoster leads to chicken pox, right? It spreads through direct contact, through aerosols. It is neurotropic. It goes to the skin and in the skin it causes the rash. What is the period of infectivity? 2 days before the rash and 5 days after resolution. So if a child gets rash today, then it would have transmitted the disease even 2 days before this, and he will continue to transmit the disease even 5 days after the rash has disappeared from the body. This is the period of infectivity of chicken pox. Very important. Okay. So there are two types of diseases by varicella zoster. One is the primary disease. So the primary disease is chicken pox, which is also called as varicella. Then there is the reactivation disease. Like I said, all herpes viruses, they cause skin infections and then they go and sit latent in the nerve roots. So HSV1 was sitting in the trigeminal ganglion and HSV2 was sitting in the sacral ganglion. Where does the chickenpox virus sit? It sits in the ophthalmic branch of trigeminal nerve. Okay. It sits in the ophthalmic branch of trigeminal nerve, and after many years, maybe when the person is 70 years old or something, the immunity is down, this reactivates, and this reactivation disease is called as herpes zoster or shingles. Okay, so zoster or shingles is the reactivation of latent VZV, whereas chickenpox is the primary VZV infection. How does the crop or how does the rash of chickenpox happen? I always tell my students to do this dance, do this and do this. Okay, so it is head to toe and it is centripetal. First the face and trunk is going to get involved and then it will move out to the extremities through the flexor surface. So this is the dance that you do for chickenpox. Okay, I hope you can remember that. So but what are the complications? Now please understand that shingles or zoster is not a complication. Not a complication. Please highlight this. It is not a complication. Okay, it is a reactivation. What is it? It is a reactivation of chickenpox. Reactivation hai ye. ठीक है? So there is one very special thing about zoster. See what is happening? It was going and hiding in some nerve root ganglion. After 50 years, it tried to wake up again, go back to the skin and cause lesions. Okay, so it was sleeping in some nerve root. It will wake up, it will climb on top of the nerve, then come back to the skin. Do the nerves ever cross the midline? No. They all come out from the spinal cord and they supply the left or right side of the body. They never cross the midline. So in whichever ganglion the virus was sleeping, it will wake up and go and cause the rashes only in that particular dermatome which that nerve was supplying. And it has to always be on only one side of the body because the nerves, they never cross. Okay, so that is why in shingles or in zoster, you will get, okay, what is happening? In shingles or on zoster, you will get the lesions only on one side of the body. So if you divide the body from the midline, this side is totally normal, whereas over here you can see the painful vesicular eruptions. Okay, this is shingles or zoster. Okay, so there is intense neuralgia. There is intense neuralgia or neuritic pain in the patient. So much so that even after the rashes have disappeared, the pain continues for many years in these patients. So what are the complications of chickenpox? Then what are the complications of zoster? Okay, they are separate. So Chickenpox is totally separate, zoster is totally separate. One is a primary disease, one is a reactivation. Both of them can have complications. Okay, both of them can have complications. So complication of chickenpox is secondary bacterial infection, because there are this the lesions on the skin and the children playing in dirt, etc. Those lesions can get bacterial infections. CNS involvement such as meningitis, etc. Varicella pneumonia can happen, which is very serious. Then there is the Rise syndrome. What is Rise syndrome? The aspirin use. So if you have a child with chickenpox, you give them aspirin, they get fatty degeneration of the liver. That is Rise syndrome. Also in pregnancy, if a mother gets chickenpox, it leads to CLIMI, cicatricial rash, limb hypoplasia and microcephaly. ठीक है. वहीं पे जो तुम्हारा zoster है, उसके specific complications हो सकते हैं, such as the Ramsay-Hunt syndrome, in which the person presents with the triad of facial palsy, lesions in the tympanic membrane and external auditory canal, and ear pain and tongue vesicles. ठीक है. Then post-herpetic neuralgia, which is the persistent pain at the site of eruptions, which is refractory to treatment. Treatment of choice for all three is acyclovir. Even after giving acyclovir, the pain in the patient does not go off. So what are the complications of chickenpox? It is Rise syndrome, bacterial infections, pneumonias and CNS involvement. What is the complication of zoster? Ramsay-Hunt syndrome, zoster ophthalmicus and post-herpetic neuralgia. Okay, three things. Right. So lab diagnosis for all three, it is Zank smear. What is Zank smear? It is a Giemsa stained smear, and you see the multinucleated giant cells with the margination, molding and multinucleation. Okay? Then if you take these and you put them onto cell lines, they will all show ballooning of cells as a cytopathic effect. Okay? What is the cytopathic effect? Ballooning of cells in the McCoy cell lines. Antigen and DNA can be detected for all, and of course serology can be done to detect the antibodies. Common lab diagnosis for all three. HSV1, 2 and VZV, common lab diagnosis is there. Right? Treatment is acyclovir for all of them. Alright? Acyclovir. Then OCA strain vaccine is present for chickenpox, and immunoglobulin has to be given to pregnant women and neonates who have come in contact with chickenpox, because congenital chickenpox is very, very deadly and very, very bad. Okay? Then you have, fine guys, I will share the notes. Okay? Viral exanthems, sorry. Yeah. All right. So, yes, we have discussed HSV, we have discussed VZV. Now, another DNA bacteria which can cause viral exanthems is parvovirus. Parvovirus B19. My students always remember that happy viruses are double-stranded DNA viruses. Parvo single-stranded DNA virus hai. So, parvovirus is a single-stranded DNA virus. It is a non-enveloped DNA virus, and it is the smallest DNA virus, right? What does it cause? It causes the slap cheek appearance inside the babies. It infects, then it goes and affects the pre-erythrocytes, the erythrocyte precursor cells, okay? And it leads to the lysis of these precursors, leading to decreased erythropoiesis. ओका स्ट्रेन बेटा कितना ऐसी एग्जाम में क्या होता है? You should write whatever you remember. Right? So if you are writing vaccine, in front of that you are writing 3 more letters, OCA strain. Whose time are you losing? Just write it. If you remember it, write it. If you don't remember it, that's a different story. है ना? चलो. So अब क्या हुआ, इन्होंने एरिथ्रॉइड प्रीजेनिटर सेल्स को इफेक्ट किया. So it will lead to aplastic crisis. It will lead to hydrops vitalis. So erythema infectiosum, or the fifth disease which shows the slap cheek appearance, is the classical feature of the parvovirus. So I always tell the students how to remember that the parvovirus, it slaps the children and it breaks the bones of adults. Okay? क्या करेगा? बच्चों को चाटा मारेगा और बड़ों की टांगे तोड़ेगा. So it will slap the children and break the bones of adults. So in children it will cause slap cheek disease. In adults it will cause polyarthritis. Okay, then what was it affecting? It was going and binding and attacking the RBCs. So it will lead to transient aplastic anemia and pure red cell aplasia. If a pregnant mother gets infected with parvovirus, the virus will cross the placenta, reach the fetus. It will go and break the RBCs of fetus. What will happen in turn? Hydrops fetalis. Now this hydrops fetalis is not happening because of antibodies. What happens in RH incompatibility? The maternal antibodies go and kill the RBCs of the fetus, leading to hydrops fetalis. Here the maternal antibodies are not coming. Here a virus is coming and causing hydrops fetalis. So that is called as non-immune hydrops fetalis. This is your congenital parvovirus disease, okay? And then finally, it can also cause a papillopruritic gloves and socks syndrome, in which there is a swelling in the hands and feet. That is why the gloves and socks or stockings. You will do the PCR as the mainstay of diagnosis. You can detect antibodies and you can detect them in the blood, serum or amniotic fluid, right? Management is no specific antiviral is there. You simply manage the symptoms, treat the anemia and of course treat the high-risk pregnant females. So what all do you remember? Parvovirus B19, single-stranded DNA, non-enveloped virus, infects the pre-erythrocyte cells. Children may slap cheek, adults may arthritis. In pregnancy, it will lead to hydrops fetalis. Okay. Transmission is of course through the respiratory route, goes to the RBCs, causes clinical manifestations, can be diagnosed with PCR or serology, and management is only supportive. Most of the things can cross the placenta. Okay. It's not a very difficult thing to do. All right. So there are few viruses which cross the placenta, and parvovirus is one such virus which crosses the placenta and causes congenital disease. So do herpes simplex, so do chickenpox. All these viruses, they cross. Okay, fine, MedPro, that is something I can do. Right? So then you have the RNA viruses, so you're done with DNA viruses. Important DNA viruses which lead to skin exanthems are herpes and parvo. Herpes 1, 2, 3 and parvovirus. Okay? Then you have RNA viruses. What do RNA virus, which important RNA viruses are there? 3. The measles virus, rubella virus and the hand, foot, mouth disease causing Coxsackie virus, which belongs to enteroviruses. These are the 3 important RNA viruses. Okay. Measles क्या है? Measles virus belongs to paramyxoviridae family, है ना? And we say कि measles क्या बोलता रहता है? Measles keeps saying हाँ ना हाँ ना हाँ ना. So it says हाँ है and ना नहीं है, right? So what are the important antigens on the envelope? It has the hemagglutinin, but there is no neuraminidase. And since it is paramyxoviridae family, so of course the fusion protein is definitely going to be there. What is paramyxoviridae family? Single-stranded RNA envelope with the hemagglutinin or neuraminidase and fusion protein. So what is the structure of measles virus? Very simple to draw. Simply make a single-stranded RNA, then give it a helical symmetry, then on top put an envelope. On the envelope you put 2 proteins, हाँ है ना नहीं है. So this is hemagglutinin, and all paramyxoviridae as a rule have the fusion protein. What's happening? Have the fusion protein or the F protein as a rule. So this is a very simple structure of measles, which is pox virus is important. Smallpox, very difficult that they will give you a short note on smallpox. Otherwise, you can just read it up quickly. Not so important. Okay, right? Chalo ji. Then how does the entry happen? Through, of course, the respiratory tract. Grows in the local lymph nodes, goes to the blood leading to primary viremia. Then, of course, affects the reticuloendothelial system, causes secondary viremia leading to skin, rashes, cough and conjunctivitis. So what are the clinical features of measles? 3 C's, Koplik spots and sandpaper rash. So how does it spread? We always make that flow chart for measles. We say that on day 10, you have fever plus 3 C's, fever plus cough, coryza and conjunctivitis. Then on day 12, you have the Koplik spots, which are the whitish blue spots on the buccal mucosa next to the second molars. And on day 14, you have the exanthems, which are the skin rashes. The exanthems, which are the skin rashes, right? Which are the sandpaper rash. And after that, there can be the recovery. It can cause complications in the brain, in the respiratory tract and vitamin A deficiency. The brain complication is called as SSPE. SSTE, which is subacute sclerosing panencephalitis, which is a type of a chronic, slowly progressive encephalitis. Respiratory में Hechet's pneumonia. Hechet's pneumonia is the pneumonia caused by the measles virus itself. Okay, measles virus itself, and everything which is present in the respiratory tract can always complicate the ear. So this can also cause otitis media. That is as a rule that it can do that. Okay, done and done. So then in the lab diagnosis, you have the Warthin-Finkeldy giant cells. Warthin-Finkeldy giant cells, which are both intranuclear and intracytoplasmic inclusion bodies, which can be seen. You can of course do fluorescence, RT-PCR, IgM and monkey kidney cell line proliferation. This is constant for all viruses. So writing lab diagnosis of viruses is very, very simple. Write antibody, RT-PCR for each and every damn virus. And then if any special inclusion bodies are there, which you remember from the mnemonic discussed in class. Okay? Live attenuated vaccine can be given for measles, the Schwartz, Edmonston, Zagreb and Muratin strain. I always tell the students it is very easy to remember the strains of the measles vaccine. Just write the word measles, okay? Measles. So this is Muratin strain, Edmonston, Zagreb strain and Schwartz strain. These are the three strains of the measles vaccine. Muratin, Edmonston, Zagreb and Schwartz. Okay, these are the three strains of the vaccine. Then you have rubella. Rubella is called as German measles. Now, it is a milder form of measles. So, it is not really the skin rashes that we are concerned about in measles. It is the congenital infection which is very, very teratogenic. That is why we detect it in the torch. It is highly teratogenic. Now, it leads to congenital rubella syndrome. And the symptoms of congenital rubella syndrome is very easy to remember. We always say that the baby has gone what? It has gone pyar mein andha behra. So, it has become blind and deaf out of love for the mother. So, love is cardiac abnormalities, patent ductus arteriosus. Blind is the congenital cataract, and it is sensory neural hearing loss and microcephaly. These are congenital rubella teratogenic symptoms. Okay? Then your measles was leading to Koplik spots. Rubella leads to Forsheimer spots. What are Forsheimer spots? These are small rashes on the uvula and the palate. Of course, IgM, IgG, RT-PCR and cell line virus isolation. Vaccination strain is the RA273 strain. Okay, RA273 strain. Finally, you have the hand, foot, mouth disease, which is caused by the Coxsackie viruses. So, I always tell my students, it is hand, foot, mouth. Foot. So, from foot you remember shoes. So, there is a very famous shoes brand called as A6. So, from A6 you can remember A6. Okay, A6. So, it is caused by Coxsackie virus A6, A16 and enterovirus 71. These are the three important Coxsackie viruses which lead to hand, foot, mouth disease. The name itself is telling you that I am going to happen in the hand, foot and mouth of the babies. So, there is vesicular eruptions in the hand, feet and oral mucosa. It is commonly seen in children involving the hand, foot and mouth. ठीक है ना? So, yes, we are done guys with the very, very intense big lecture. Now, I want you to go and watch FARRE 2025 for anthrax and gangrene, and I want you to watch it for the systemic mycosis, for the fungal infections. Okay, another thing that you can do and go and read up a little bit about smallpox, a little bit about molluscum contagiosum virus, and a little bit about HPV because it causes the warts. So simply read up few lines about it and you're good to go, and skin and soft tissue will finish off. ठीक है? That has been covered na beta, that has been covered. Parasitic is not very, very important. You only have to talk about larva migrants. That has also been covered in the 2025 FARRE lecture. Okay, so 2025 FARRE lectures are covered. Important topics वही हैं जो मैंने बताया है. University exams are quite unpredictable. So we have done covered most of the topics. So you can get measles, you can get I mean, everything that we are covering are important topics. You just need to revise everything quickly. Otherwise, for university exams, the must-know topics, they depend upon the previous year papers of your university, right? So pick up your whatever little, step or whatever those books are called in your universities. Pick them up, mark your books with the seniors, because your university's PYQs are must-know. And after that, of course, we are trying to cover each and every topic at length by quick revision through these lectures. Okay. Oh, I'm fine, guys. It's just a splint that I have put to give rest. Okay. Thank you so much, guys. Good evening, and I will see you. Pyogenic liver abscess. Beta, we will cover that in. We have covered that in. Okay, pyogenic liver abscess. That's okay. That's just a bacterial infection. नहीं पूछेंगे mostly. Okay, even if they ask you, you simply write everything you know about liver abscess and just tell that it happens because of bacteria. Amoebic liver abscess, on the other hand, is an important question which has been discussed in hepatobiliary lecture. ठीक है ना? चलो, thank you so much, guys. Good night, and I will see you in the next session soon. Thank you. Good night. Bye bye.